Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Dr. Edward Barnes. Dr. Barnes is a gastroenterologist and clinical investigator at the University of North Carolina School of Medicine. He's also the 2021 Sherman Emerging Leader Prize recipient. We talked to him about his dedication to improving the care of patients with inflammatory bowel disease and his particular interest in improving outcomes for patients with J-pouches. As you can imagine, we talked to him about all things J-pouches. We talked to him about caring for patients who need J-pouches, introducing this as a treatment option, mental health and J-pouches, what to expect with a J-pouch, and so much more. We had such a great conversation. Cheers!
Hi, everybody. Welcome to Bowel Moments. This is Robin.
Hey, guys. This is Alicia, and we are so excited to be joined by Dr. Edward Barnes. Dr. Barnes, welcome to the show.
Thank you so much. This is really a pleasure to be here. I've enjoyed listening to some of the other podcasts, so I'm glad to be able to join with you guys.
Well, thank you for that. We appreciate it, because I was going to say you said that, but you haven't even started with us yet, really. So you may change your mind. We'll ask you. We'll ask you again at the end.
Okay, fair enough.
But our first question for you is always somewhat unprofessional. But what are you drinking tonight?
Well, I'm still sitting in my office, but that wouldn't really change because about 90% of the day I am walking around with a travel mug of coffee. So I'm still drinking my coffee, even though it's 6 p.m. here in North Carolina. And it will not be my last cup of coffee today either. So
you sleep?
It's a good question, but it doesn't faze me. I can drink a cup of coffee and go right to sleep for whatever reason.
Yes. Yeah, our last interview that we recorded, it was 7 or 8 o'clock at night, and I was drinking coffee too. I'm the same way.
Meanwhile, if I have caffeine after noon, I'm awake until tomorrow.
I support you. I support that.
I would do it if I could. I like coffee. Robin, what about you? Are you also drinking coffee?
I am not. I'm about to shock you, Alicia, because Dr. Barnes, you don't know this, but probably for the past 12 or even more episodes that we've recorded, I have not had an adult beverage, and I am having an adult beverage tonight. I'm just going to I'm having a little cider.
Well, cheers, Robin. I'm glad to see you back again, and I'm glad it's a little bit. Hopefully that means it's good news for you.
Yeah.
I am drinking Prosecco today, so I'm back to the bubbles, but I'm at my mother's house right now. And so I raided her fridge, and that seemed like the best option, considering I think the other was like Bud Light Lime. And that's not happening for many, many reasons. So sorry, Mom. I know you listened to the episode. So, but anyway, again, Dr. Barnes, such a pleasure to have you on the show. Thank you so much for coming. Oh, I forgot. Yeah. Cheers. Again, such a pleasure to have you on the show. Next question for you is, what brought you into the IBD community? Why did you decide to become a gastroenterologist, and why did you decide to specialize in inflammatory bowel disease?
This is a bit of a long road, but I will give you the very short version. When I was in college, I actually did a summer. I spent a summer doing colon cancer research, and I was doing bench research. And I will, to my basic science colleagues, don't take this the wrong way, but it wasn't the most exciting summer that I ever spent from a research perspective. But that being said, what I really enjoyed was the idea of prevention and the idea of colonoscopy as a way to prevent colon cancer. And so I really got interested in GI from that really time point, and that interest grew while I was in medical school. But one of the things I did not know a lot about during medical school as far as a career pathway was inflammatory bowel disease. And I came to UNC actually as a fourth-year medical student, did a visiting rotation. And I happened to work with two of the preeminent IBD experts in my mind in the country, who are Kim Isaacs, who just retired from UNC, and then Millie Long. And over that month, I just learned so much about all the things that I liked about internal medicine that they applied to the daily care of patients with IBD. They knew everything about the inpatient service. They knew everything about outpatients. They knew what medicines these patients had been on. They worked seamlessly with surgery colleagues and radiology and pathology to make these decisions. And all of this left me at the end of that month saying, not only do I think I want to do GI as a career, I think I want to do residency at UNC, and I think I want to specialize in IBD. And so I came here the next summer, and I met with Kim very early on and said, how do I learn more about Crohn's disease, ulcerative colitis? How do I learn about this career path? And I started doing research my intern year, and sort of one thing just led to another, and it really just blossomed. And I'm happy to expand on any of that, but that really was probably, if you think about months of my life, that was probably the most fundamental months, because I pivoted a lot in terms of what I wanted to do after that month here at UNC.
That's really remarkable to hear. And it's always interesting to me that the people like you who maybe didn't come in with a specific, tie to the disease, but just met somebody that rocked your world and said, and made you decide that you really wanted to do this as a career. I always think that's so inspiring to hear.
Yeah.
Yeah.
And also I know people can't, we just use the audio. We don't use the video, but like watching your face as you just talked about it as a patient, I'm like, do I need to move to North Carolina so you can be my doctor? Like, honestly, just watching your face while you're talking about it, you can just see how much it means to you and like how much your perspective changed just in those few sentences about wanting to take care of people with IBD. And so, Matt, if you're listening to this episode, start looking for houses in North Carolina. Okay, thank you.
I mean, that's a beautiful place to go, Robin. I fully support you doing that.
No, I appreciate that very much. And it really is. It's your point about who you work with inspiring you is a really important one, because I could have easily not been paired up with the two individuals that I mentioned, and maybe my career goes a totally different way. I like to think that it wouldn't have, and that, I really am drawn to this field for the reasons that you said, Robin, and that it really was a great fit for me. But you're right. You really get shaped by experiences that you have. You get shaped by people that you work with. And I've tried to turn that around and mentor as many people as I can too now in my new roles as my career has developed, because I think you're right. You have all these sort of touch points where you might change somebody's sort of career trajectory, at least from the medicine side.
Yeah, it's nice to feel like you're carrying that torch forward and getting other people inspired as well. So that's super cool. I'm curious where your special interest in pouches, J pouches, came into this story.
That actually is pretty similar to what I just said about people changing your life. But I did my fellowship at Brigham and Women's in Boston. And one of the things that I did while I was there was I got a master's in public health. I really knew I wanted to do research and I wanted to be focused in research. And I really was focused, a lot of my training there was really focused on decision-making in IBD, how we use medicines, when we use surgery, these kind of things. And I was trying to figure out how exactly I was going to apply all of this sort of foundational skill set that I had to a research career, but also to a clinical career of interest. And I was interested in quite a few things. When I came back to UNC for an IBD fellowship, one of the things that had happened while I was gone is that one of my mentors, Hans Herfarth, had started a pouch clinic. And so every Wednesday, I was spending the entire day in our pouch clinic. And that was something that I really hadn't been exposed to before. And all of a sudden, I started asking all these questions about how we manage patients with pouchitis and with chronic inflammatory conditions of the pouch, to say, why don't we use the same sort of evidence base in pouchitis and in Crohn's-like disease of the pouch and chronic antibiotic refractory pouchitis? Why don't we use the same sort of epidemiology and decision-making and all the things that we do in Crohn's disease and in ulcerative colitis? Why don't we do that in pouches? And Hans, and I would have these in-depth conversations. At the end of the day, he would say, I don't know. Why don't you figure it out? And so he and I started to do that, because that was one thing I really wanted to do. I had this skill set that I wanted to apply to somewhere where I thought I could make a difference. And all of a sudden I realized this is a very sick population. This is a population that really needs answers. And we could probably do a lot better if we sort of took a step back and we tried to treat this more like Crohn's disease and ulcerative colitis, using all these epi principles that we've used for 20, 30, 40 years, apply that to how we study pouches. I think we can do better. And so that sort of blossomed from there. And that became really my passion in terms of clinical care and research.
So you mentioned, kind of using some of the same tools that you're using to try to figure out Crohn's and ulcerative colitis, but using it in the pouch population. First question for you is, why wouldn't that have been happening? Number one, yeah. But also number two, after you answer that question, I want you to start talking about the paper that I found where you were talking about biomarkers and some of these newer techniques that are coming out or diagnostic tools that are coming out and how you've now seen them used to help people with J pouches.
I think both are great questions. The first question is a really important one. And some of this comes down to clinical care and some of this comes down to research. So I'll answer it in two ways. From a clinical care standpoint, a lot of what we had done was very much based in where you were and where you were practicing. So, for instance, you think about pouch center meccas, Cleveland Clinic, Mayo Clinic, Mount Sinai, Cedars-Sinai. There's a certain style of practice that was done. If you look at the literature, they would publish on what they did and what was successful. But that may not translate from one center to another center. There was sort of these one-off, even large populations, but one-off sort of reports of how things were done. And that's also how we were practicing in the clinic. If a patient came in and they had chronic antibiotic-dependent pouchitis, for instance, we would just use an antibiotic that was working. And then if it stopped working, we would use a different antibiotic. And if they developed a new chronic inflammatory condition of the pouch, we would just use a biologic or a small molecule until that one stopped working. Then we'd use another one. And it wasn't very algorithmic and it wasn't very standardized. And part of that, getting to your question, came from research as well. Because if you think about how we know about sort of small populations in Crohn's disease and ulcerative colitis, if you think about incidence rates and prevalence rates and rare complications like cancer, like melanoma, for instance, a lot of that data has come from large administrative claims databases. One of the problems in pouch care is that we haven't traditionally used ICD-9 or ICD-10 codes. And so because of that, we couldn't find patients in administrative claims databases. And so you had to rely on these single center studies. And so one of the first things that I did from a research standpoint, and this was one of the career development awards that I got from the Crohn's and Colitis Foundation, was actually find a way to find patients with pouch-related disorders in administrative claims. So that instead of knowing what one center did, we could actually look at generalizable population estimates across the United States. And so that really unlocked a lot of different things to say, do the population estimates across the country from these administrative claims match what were coming from single centers? And then you can start to do all kinds of studies like we do in Crohn's disease and ulcerative colitis, comparative effectiveness studies, looking at different antibiotics, looking at different biologics. All those things become unlocked when you don't do these small single center populations. The second thing that we then did was we started to build prospective registries, and not just single center prospective registries, but multi-center registries, so that we all spoke the same language. We all knew what patients looked like when they came in, and that we were all trying to get sort of standardized outcome assessments at the end to try to improve care of patients as well. And that's been something we've been really involved with for the past several years in a study called PropRD. To your point about biomarkers and sort of where this field is going, I think this has led to a real push to understand why, for instance, patients develop chronic inflammatory conditions of the pouch, and why maybe we can, or how maybe we can find those patients that are at greatest risk early on. There's a lot of traditional biomarkers that have been identified. Some of these are serologic biomarkers or genetic biomarkers. And one of the problems with these is they haven't really been translatable from center to center or even population to population, or they aren't really biomarkers that you can sort of act on to sort of change your trajectory. If you think about something like p-ANCA, up to 3/4 of patients in these studies would be p-ANCA positive at the time of their colectomy. So that's a very strong marker.
What is that?
Yeah, it's a serologic test. It's a serologic biomarker. And so if you think about p-ANCA, which is a serologic biomarker, about 3/4 of patients will have this p-ANCA positive test at the time of colectomy. Well, it's hard to risk stratify a population if 3/4 of patients have that, and sort of to act on that to say that you're at risk for pouchitis. This has led to some other sort of more novel approaches, looking at things like the microbiome or bile acids, or even looking at things like tests that we use in ulcerative colitis and Crohn's disease, like calprotectin, to see if you see a rise in calprotectin before a patient ever develops symptoms of pouchitis. Maybe we should be doing more routine monitoring to sort of see those patients that are at risk, and then do something before they develop frank symptoms of having inflammatory conditions of the pouch. So I think that idea of flipping our mindset of risk stratification, and then also thinking about who those patients are at risk and identifying them early, that's really where our field's probably going.
Super interesting. Okay. When you and I were chatting before Robin was able to get on, you and I were chatting that there's multiple centers that are creating pouch clinics or within their centers. What's encompassed in a pouch clinic? How does that make that different than just somebody seeing a pouch specialist in a hospital or in a clinic setting?
I think from a patient perspective, one of the things is that you don't necessarily change who you're seeing in terms of gastroenterology care. But if you're in a pouch clinic, often what's going on is that you're either having a dedicated team of gastroenterologists, surgeons, pathologists, radiologists that are really focused on the care of patients after an ileopouchianal anastomosis, both those with inflammatory conditions of the pouch and those without. And often there are, in the current era, it's a central place where there's a lot of people that are, excited about taking care of patients with pouches, but also have seen patients with very refractory diseases. And so they're willing to really think outside the box. And what I mean when I say think outside the box, they're really pushing the envelope. And if you think about some studies that have come out recently with hyperbaric oxygen, or looking at non-inflammatory causes that people have symptoms, like a lot of the work that Laura Raffles has done at Mayo Clinic, looking at functional pouch disorders and anorectal manometry and using biofeedback, and that actually a functional pouch disorder or a functional pouch emptying disorder may actually still drive some inflammatory conditions of the pouch with people with chronic pouchitis. So thinking about this in multiple different ways, other than, as I sort of alluded to, off the cuff to a bit at the beginning saying, if you're not doing well, we change your antibiotic and we hope that you do well. Thinking about this in a much more multidisciplinary way. I think people are much more focused on this, which is really would say not that different from what we do in Crohn's disease and ulcerative colitis. If you think about the big pushes in the last couple of years for patient-centered medical homes or these kind of models where you have multidisciplinary care with nutrition and social support and even psychosocial support, we're trying to do this in pouch care as well.
Got it. Okay, that's very helpful. And I really like the idea of it too. I like the idea of a whole group of people that are just like really trying to make sure they're helping these folks be as successful as possible with this big surgery. Because I mean, this is a big deal to have your colon removed and to go a year through the surgery and all these, things that encompass part of it. Learning to go to the bathroom again is alone just a really hard thing. One of the things I mentioned to you that I appreciate and that Robin and I both appreciate is that you also, I found an article that you had written about mental health and not forgetting about mental health in the grand scheme of this. So I love that. Number one, that's great. And I definitely want you to talk a little bit more about what prompted you to write that. But here's my real off the cuff wildcard question for you. As I mentioned, J-pouch surgery is a really big, complicated surgery that comes with a lot of its own sort of emotional recovery that has to come from that. But I'm curious that since you see the folks that perhaps their pouches are not working for them the way that is ideal, whether you see an increased amount of like quality of life concerns, depression, anxiety, and general sort of, dissatisfaction. So whether those mental health conditions sort of flare within this population specifically, and have you tracked that? And what are you seeing that maybe is same and different?
So many great points in there. And I want to just try to take this one by one because I want to make sure I don't gloss over any of the questions that you asked. The first thing I would say, and I can't believe we're 15 minutes into our discussion that I didn't say this. The other reason that I got interested in pouchitis is, and inflammatory conditions of the pouch, but just pouch care in general, is your point is such an excellent one. If you think about the majority of people that get a pouch in the current era, most people come to a pouch after having had some terrible course with ulcerative colitis. And they were told, if we take your colon out, then you're going to feel better. And then all of a sudden you come to this pouch clinic because you don't feel better. And maybe you even feel worse. And maybe you have a new complication, which we haven't really gotten into, but like Crohn's-like disease of the pouch, and you've got a fistula, and you never had a fistula because you had ulcerative colitis, because by definition, we don't think about that happening. I think that's unfair. And I personally don't have a pouch, but I take care of a lot of pouch patients. And I think that's unfair. I think it's unfair in the sense that we can't tell you at the time you have your colectomy what your individual odds are of any of these things that you just alluded to happening. And that's where, as a field, I think we can do better. Because the second part, and really the first part of your question, how does mental health play into this? Yes, it has a significant impact on an individual patient's mental health because of some of the issues that I mentioned before, but also because if you think about having an inflammatory condition of the pouch, for instance, you're going to the bathroom 15, 20 times a day, just like you did when you had bad ulcerative colitis. Well, we actually know pretty reliably from ulcerative colitis data and from Crohn's disease data that increased stress increases your disease activity, and that in periods of disease activity, you have increased stress or anxiety or depression, however you want to think about this bundle of psychosocial care. So I think that all of these are important because we probably will never be able, I know the audience can't see my hands, we'll never be able to balance these things out unless we come at this from multiple different ways. And so I think for us, in the way that we approach patients with pouches, especially patients that are having difficulties with their pouches, we acknowledge this up front. Yes, this is going to take its toll on your quality of life. We don't have great objective ways to measure this at the current time, but there's a lot of actually interesting work that's going on to do that better from a patient-reported outcome standpoint and from what quality of life should look like. But we realize it's important, and we're willing to either we can prescribe medicines to help with this. We can work with you to find psychosocial counselors that will help if you would rather go that route. And we try to find those personnel that will be most helpful while we're also trying to treat the underlying problem that you're presenting with, whether it's, as I mentioned before, an inflammatory condition of the pouch or an emptying problem or whatever that is. But to think about this being isolated in a bucket where you come to a gastroenterologist and they sort of give you a magic bullet and they say, you're going to feel better in 2 days. I don't think that happens in the current era because this is a big surgery people have been through. And that's where I think I'm motivated to do better.
Okay. So what about the opposite end of that? How's the pouch supposed to be? Like, what about how's it supposed to be when it's working? How are you supposed to feel? How many times should you be going to the bathroom? Like, what's the opposite end of that?
Your question is a really good one, Robin, because luckily, most people that have normal pouch function don't have to come to a pouch clinic. So they have their surgery and they do quite well. And then maybe they see their gastroenterologist for a surveillance pouchoscopy every once in a while or something like that. But they're not the ones that are coming to pouch clinics so frequently. So what I typically tell folks, and I think surgeons would counsel people the same way, is somewhere between 4 and 8 bowel movements per day, no more than 1 bowel movement per night. That's normal. But Alicia, you said this earlier, there is an adjustment. You don't sort of have your surgery, go home the next day and have 4 to 8 bowel movements per day. So you really need to have an important conversation about expectation setting. And I hope that that's coming more from the surgeon than the gastroenterologist. I try to have these conversations because I think that people need to be aware of it, but also I think you need to hear it from your surgeon because that's the last person you're going to see before you walk out the door of the hospital. So that needs to be sort of re-implanted, that expectation. So that's what I think normal pouch function should be. The way I describe it to people when I'm talking to people in clinic when they're considering colectomy is you're going to have 4 to 8 bowel movements per day, but the normal expectation is these will be controlled bowel movements. And if you're having bad ulcerative colitis, perhaps you're not having controlled bowel movements. You're either having significant urgency, you're waking up in the middle of the night, you're not able to control, maybe you're having incontinence or you're having a lot of bleeding. By the time you get a pouch, if everything goes well, these should be controlled bowel movements so that you can make it through dinner, or you can make it through a movie, or you can make it through your meeting at work. And that should be the expectation. If you go back to 1 bowel movement per day that's formed, that actually is not what your pouch is supposed to be doing. That is indicative of a problem. And so patients should understand that when they're going into the surgery. But somewhere around there is important. The second piece is sometimes people will have to take Imodium, or sometimes people will have to take Lomotil to get to that range. But as long as they're in that range and they're not having problems and their quality of life is good, and it is in sort of the normal range, I think that that's sort of a reasonable expectation.
Thank you so much for saying that about the 1 bowel movement a day. If anybody has listened to this show before, we kind of talked, friend of the show, Stacy, who has had J-pouch surgery around the same time that I did. We kind of did a couple of shows over the year after our J-pouch surgeries to kind of say, like, this is where we are now. This is where we are now. And so it is a learning curve. Your small intestines is learning how to function all over again. It's not just going to bounce back. It's learning how to be a whole new organ, basically. So it takes time. Even 2 years out, it still takes time. Like, that's just what it is. So that's kind of why I asked that question. But I think that sometimes on the internet, when you get to searching and Googling and falling down rabbit holes, there's some misinformation about there that people think that they're going to get back to that, 1 or 2 form stools a day. And that is not a reality that you should be planning to get back to, because you don't have your large intestine. And so your body's not going to function that way again. So if some kind of guru is telling you that they're going to get you back there, that's a red flag, everyone. Please don't buy what they're selling. That is a red flag.
So you're telling people if they're having 1 bowel movement a day and they have a J-pouch, they should go see their gastroenterologist.
Probably, because to Robin's point, the way I sort of frame this also when I talk to patients is the reason we're even talking about taking your colon out is because the major job of the colon is to absorb water. And that's what gives you more form stool in most cases. And so in that situation, Robin's exactly right. Your expectation can't be to have 1 form stool per day, because the small intestine will never have the capacity to take all the water out of the stool to make it that way. And also, even though the J-pouch is going to be compliant, and over time it's going to become more compliant, it's never going to be exactly like a rectum is without having inflammation and ulcerative colitis. And so I think Robin hit the nail on the head. Like those are critical points. And we as a field in gastroenterology have to make sure we're getting that message out along with the surgeons that are doing the surgery.
Yes, agree, totally. I realized we didn't ask this, Robin, of any of the folks we've talked to, and we've talked about J-pouches, but we've had a couple of surgeons on now, and you just mentioned making sure the surgeon is the one that probably would have that conversation. But when people are going through this J-pouch surgery, where do you come into that process?
I'm probably a little bit different than most gastroenterologists in the sense that, I'm sending my patients to colectomy if that's the route that they're choosing, but also I'm, heavily counseling them about what that's going to entail. And then I'm also seeing my patients in between stages of the J-pouch surgery to make sure that things are going well. And this is not evidence-based at all, but in some patients that I think are high risk based on some early research that we're doing, we're talking about things like, should you do prophylaxis, and what does prophylaxis look like to prevent pouchitis? And so I want to be very clear, there's not great evidence for that. There is some evidence in terms of probiotics, and I'm happy to talk about that, but some other high-risk conditions, probably not. But I see my patients in between stages to talk about some of these things to make sure they're doing well. On the other side, if it's another gastroenterologist patient, obviously they may or may not be doing the same thing. But I would say traditionally, it's more the surgeon driving the show. And then there's always this sort of gray zone, which I'm glad you asked the question of what happens a month after the patient has surgery. And the patient has a question. Do they call a surgeon? Do they call their gastroenterologist? Me personally, Robin, I hope what you said was true earlier. I like my patients. I want to know what's going on. So if they have a question, I want them to call me, and I'm happy to communicate with the surgeon too. And they can call both of us, but I want to know. But that has been a traditional sort of gray zone. And we think about something like pouchitis. Sometimes patients are unclear who to call during that first 6 months after surgery if they develop pouchitis. And sometimes it can differ, and practices may differ on how that first episode of pouchitis gets treated.
Also, during that time, are you regularly monitoring like labs and blood work and things like that to check for nutritional deficiencies or other things like that? Is that something that you regularly do with somebody, or do you wait to say, oh, I think this person is looking a little anemic, for instance?
It depends in each individual. And that's such a great question, because there are some patients that they'll have their colectomy and they'll have an endoleostomy if it's a 3-stage approach. And the morning after they have that endoleostomy, they will feel so much better because they don't have all that inflammatory burden that they've been dealing with for however long they've been dealing with is gone. There are other patients that in that same surgery that still have that rectal stump, that have such bad inflammation in the rectal stump, they continue to bleed, they continue to have tenesmus. So everybody's really individual. And so I sort of judge it based on what the patient's symptoms that they're having, because there are some patients where you do worry about nutritional deficiencies and healing and those staple lines and all of those things. And so that's a hedge answer, and I totally get that. And that's terrible for a podcast because people are going to come away being like, this guy doesn't know what he's talking about. But it's really, really individual, because you have to know your patient. You have to know what they were like going into surgery, and then where your sort of level of concern is in between that sort of 3, 6, 9 month process when they're having the next couple of stages of surgery.
We prefer the individualized approach.
Okay.
Yes.
Yes.
We prefer that.
Okay. And I highly doubt that anybody listening to you is going to be like, that guy doesn't know what he's talking about. So I think you're doing okay.
Okay.
Yeah.
So yeah, I think the personalized approach makes a lot of sense, because it's exactly like everybody's IBD. Nobody's IBD is exactly the same. No matter how many people we've talked to, it's been entirely different. In some of our latest episodes and guests that we've had on, we have mentioned that, talking about pouches and how they're problematic. And I said that it feels like the last couple of guests that we've had, or there's been a number of folks we've talked to that have had J pouches that have now been diagnosed Crohn's disease or something that looks like Crohn's disease. So we got Dr. Schwartzberg's opinion on this. And so I'm curious to hear your thoughts on this as well.
And this is a really important topic. And this is one where I think as a patient, it can be very confusing. So I'm going to try to lay this out in a way that hopefully is a little bit systematic, but also makes sense. If you just PubMed this idea of Crohn's disease after an IPAA or Crohn's disease of the pouch, there are so many different terminologies that are used in the literature. There's been a lot of different diagnostic criteria through the years that have been used in the literature. So it's hard. I get it. As a patient, it would be very hard to understand like what's going on. And perhaps the toughest thing about this, and where I would push back on many cases, on not all cases, is the idea that you had ulcerative colitis, that I alluded to earlier, and that you got a colectomy, and then now you have Crohn's disease. I think about this in a little bit different way. I think about this as you had ulcerative colitis. We did a colectomy for that reason. And now you have this thing that looks like Crohn's disease. And oftentimes this now is being termed Crohn's-like disease of the pouch. Because in most patients, it's probably not de novo Crohn's disease. the way that it is if somebody presents with terminal ileitis when they're 18 years old. It's probably something a little bit different than that. The reason that I say that is because you guys have so many guests on, you have so many great opinions. One of the things that I think we've done poorly in IBD through the years is put people into buckets and try so hard to put people into buckets of ulcerative colitis or Crohn's disease. Who knows how many types of inflammatory bowel disease there really are? And maybe the patient that has a colectomy that gets up for ulcerative colitis and then develops something that looks like Crohn's disease after they have surgery, maybe that's IBD number 21. And that's the 10% of patients that develop this thing that looks like Crohn's disease, Crohn's-like disease of the pouch. That's what I'll usually counsel patients on. It's about 10% of the time this happens. And oftentimes we will have to treat these patients with either biologics or small molecules, the same type of medicines that we use for Crohn's disease and ulcerative colitis de novo. Your question about, is this happening more often? I think is a really good one. We did a systematic review and meta-analysis a couple of years ago looking at all population-based studies, and that's where this 10% number comes from. But if you actually look at the incidence of pouchitis, so not Crohn's like the pouch, but just pouchitis, it looks like the incidence of pouchitis is increasing in recent decades. And this in part comes from some work that we did in Denmark with the Predict Center, which is headed by TDS. But the idea here, in my mind, going back to this idea of a specific type of IBD that presents like this, maybe your disease was so bad when you didn't respond to a lot of different medicines that we offered you for ulcerative colitis, and then you had surgery, and now you're showing up with a new inflammatory condition of the pouch right after you had your pouch surgery. Maybe this is just a continual phenotype, and so patients are having inflammation in their colon that's then now later presenting with inflammation in their small bowel after they have surgery. It's a little bit theoretical, and to backtrack a second, we don't have a biomarker for that. I think if we had the right biomarker for that and we knew that that was a potential result, maybe we would treat patients totally differently. If we knew you were at really high risk of developing this, that you might fit into this category, maybe we would continue using biologics or continue using small molecules or try to prevent these complications from happening. Because I think you're right. This does seem to be happening more. And just to your other point earlier, there are more and more centers with pouch clinics. And so, you don't need a pouch clinic unless patients are having problems. And so I think that's a different very 10,000 foot view way to think about that.
As a person with a J pouch, living with IBD for 20 plus years, it just seems that it is the more severe cases, right, who end up having to have surgery. And so it makes sense to me that those people end up having inflammation that extends past their colon once they've had surgery. Like that just seems a logical extension of what happened. So they had very severe inflammation in their colon, so severe that they had to have surgery. And so where does that inflammation go when that organ was removed? It goes to the next place that it would have gone. So that's why, I'm like, it doesn't seem like it's such a huge jump logically to say like you removed the colon, so now the inflammation moves to the small intestine.
But Robin, is that an argument to have surgery sooner then so that it prevents it from being that inflamed?
I am always a proponent of surgery as a treatment option and not a last resort.
We're also not doctors too. So there's,
I don't think that you should have surgery first.
Right. Yeah.
But sometimes, again, not a medical professional. Also don't think that you should wait till the patient is malnourished, super sick, not able to recover, like all of these other things. But again, I'm not a medical professional, but I also have been malnourished and had to have surgery and then almost died and ended up in ICU and had a very hard recovery. And all of these things happened to me. So I just feel like you shouldn't wait until it's the last resort to have surgery. And so there's so many things that could be done differently, wider. I think a lot of places already do them differently. And I think that more places need to do them differently. But that's why we have experts like Dr. Barnes on the show, so that Alicia's and my opinion do not overshadow.
No, I completely agree, Robin, that surgery is always an option. And I think that that's how I talk to patients about this one, especially when they have severe ulcerative colitis. One thing that you made me think about, that I often think about, but that your comment actually made me want to just say this, because I wanted to say this at some point during our discussion anyway. If you think about what we do for Crohn's disease, we think about Crohn's disease just how you described it, Robin, in the sense that if you have really bad Crohn's disease, you have a stricture. We don't continue to treat you with biologics, so we don't continue to treat you with small is we take that stricture out, we put the bowel back together, and then what we do is very regimented. It's very augmented, it's very algorithmic, and it comes from guidelines from the AGA and the ACG and from ECHO to say we do a colonoscopy at 6 months after surgery, we see if you have inflammation, we change your therapy if you have inflammation, and we try to prevent you from having recurrence of your disease. Now, counteract that to what we do for ulcerative colitis. We do a colectomy. If you get a restorative surgery, in most cases you get a pouch, and then we wait to see what happens. That's where I think as you said, Robin, we need to think about this a little more widely and say, maybe we don't need to be just waiting until people have problems, but we actually need to take that Crohn's disease approach. Now, the difference is we have randomized controlled trials in Crohn's disease to inform how we do things, and we just haven't done that in ulcerative colitis traditionally, but that's where I'd like to see us go.
Yeah, that seems to make a lot of sense that would be the approach you would take. Some of what you're talking about, one of the things we mentioned chatting offline is that you and also, oddly enough, Dr. Schwartzberg, who we had on earlier, are talking about there's some additional opportunities that are going to be happening within the literature to be able to really highlight some of the research that is happening in this area. And you happen to be the editor of this journal, did you say?
I'm one of the associate editors for IBD Journal. And one of the things that Dr. Schwartzberg had brought up is the idea of having a sort of pouch-focused area. And so that's how he and I have sort of interacted about in recent months about doing this. This is not something that's totally approved yet. And so I don't know if it will be, if it would, but it seems like a great idea to us. And I've been talking to the editors of the journal to see if we could possibly move this forward. So I think it's a great idea. I think it was very forward thinking from him and from Maya Kayal, who is at Mount Sinai, also to bring this forward. There are two other doctors that are really focused in improving care of pouch patients, one from the surgery side, one from the gastroenterology side. So I think it's a logical sort of grouping because, as you alluded to, Alicia, we have seen this sort of abundance of really well-done pouch studies in the past, 6 months to a year, even including the first randomized controlled trial that we've had in patients with chronic pouchitis, in essentially other than one other study of adalimumab, which was the EARNEST study, a comparison of vedolizumab versus placebo. That was published in the New England Journal. So we're seeing sort of the level of evidence ramp up in terms of how we care for patients with pouches. So to me, it seems like a logical extension to think about how we focus our literature and make sure that message that Robin was talking about earlier is getting widespread, that we are trying to make sure that people are aware of what's going on in the field.
That's very cool. And I think it's really necessary for all of the folks to hear this and to know that they can find that source of literature, in what you guys are doing. So that makes a lot of sense. I'm going to take a little bit of a turn with you on this one, because again, I did a little bit of research on your papers, and I found one from back in 2020 that was talking about the effects of race and ethnicity on diagnostics and management of inflammatory bowel disease. So I really would love for you to talk about that research that you did, because one of the things I noted in there is the effects of factors such as access to care, delays in diagnostics, and health and disease perceptions on disparities in IBD. So would you mind talking about that literature a little bit? Because I really think this is an important topic for us.
It's a critically important topic. And although most of the time when I get invited to speak about things, it's often related to my work in pouchitis or my care of patients with pouches. But I think this is a critically important area, as I already said, because this impacts how we care for so many patients with inflammatory bowel disease. And it actually is an area where I've continued to do research because I think it's important. And I think it's research that needs to be done. You alluded to several different important aspects where we see disparities in care in patients with Crohn's disease and ulcerative colitis and with pouches as well, that I think are really important to highlight and have been really difficult to disentangle as far as what drives outcomes in IBD. That particular article, we really focused on the impact of race and ethnicity on outcomes. But one of the things that you said very nicely there is that this can't be unpacked from access to care, because so many times race and ethnicity is used to talk about disparities. But the literature, even from a decade ago, from Johns Hopkins, would say that patients that were of Black or African American race were potentially less likely to use biologics or were less likely to see a gastroenterologist compared to their primary care doctor. But that also may have been due to geographic access issues getting to clinic or just transportation issues getting to clinic. And if you take that further out, one of the things that's been a real big interest in the past several years within Crohn's disease and ulcerative colitis trials is making sure that our trial populations are representative of the diversity in the United States, but also the diversity of patients that have inflammatory inflammatory bowel disease. Well, this also really breaks down in terms of access to care, because if you don't have access to an IBD center that's doing clinical trials, or that IBD center is 4 hours away from where you live, if you live in a rural area, particularly of the South, like where I live, we see patients from all over North Carolina, South Carolina, Virginia, Tennessee. If you can't make it to the frequent visits that you have to for a clinical trial, or you don't have great internet access at your home, and you can't do the stool diaries to be in a clinical trial program, well, you can't participate in the clinical trial. And that's true for patients of all races and ethnicities. And so all of a sudden you see a geographic disparity that totally exacerbates every other disparity that we wrote about in that article. So I think that we need to refocus our interest in terms of disparities on race and on ethnicity, because that has generated a lot of sort of diversity discussions, including in our major conferences. Like we had a very interesting panel and sort of oral presentations at DDW this year. Same thing at Crohn's and Colitis Congress in January. But also we need to think about the other particular disparities that may exist that may exacerbate those as well. And I think that's why something like access to care is really important.
Well, and one thing I think that is an adjunct to this is, and that we've talked to one other doctor about, and I know we've brought up with other ones, is also, especially for somebody like you with a pouch interest, when you start bringing in the LGBTQI plus community, like, again, how are we ensuring that those folks are really feeling heard and served by our doctors, especially when sometimes these choices to get surgery are happening pretty young and you maybe don't understand the ramifications of the surgery and what's really going to happen to you. So are you comfortable talking about that?
Absolutely. And I think when I said before that we had this panel discussion at the Crohn's and Colitis Congress, one of the things that was really important is that we actually had a representative from Mayo Clinic, Victor Chedid, who has started the LGBTQ clinic at Mayo Clinic. And so we're thinking about not only just being cognizant that these issues may exist, and that these issues may particularly happen in young patients where there's a lot of things that are going on in terms of decision making for their care for IBD, but also not just saying, okay, I may see these patients in the context of my normal pouch clinic or the context of my normal Crohn's disease and ulcerative colitis clinic, but that actually, when we think about access to care and when we think about disparities, we actually need to be focusing our efforts on making sure these patients are getting equal care to every other patient in our clinic. And I think that's one thing that Victor did a really nice job of summarizing what his work has done and where disparities may exist in these populations, and how increasing that representation in a clinic that he set up, a really specialty clinic, that can be really important. And now at the same conversation I had at DDW, they actually were talking about that at UCSF. I think they're starting the same model that will be starting like in July or August. So I think you're starting to see these in these major IBD centers. There actually is a new focus to make sure we are delivering care to everybody, and care in a comfortable way where they feel like they're getting the care that they deserve, which I hope answers your question, because I think it's just as important as any other disparities that I mentioned.
Again, we hadn't hit record yet, but you mentioned Sonia Friedman. And when she was on the show, she specifically talked about the importance of you as a gastroenterologist bringing up sexuality proactively with your patients, so that it isn't a guessing game. It isn't something that you kind of go, oh, wait a second, I didn't know that this was this aspect of your life, because there are, again, ramifications of the decisions that you're talking about that could be very specific to somebody's culture or to, their personality and the things that they like. If you're a vegetarian, telling somebody to eat more protein in the form of meat is not very sensitive. That's a bad example compared to the other ones, but you know what I mean? So I do think it's an important thing to talk about, because again, even just thinking about something like, some reticence to participate in clinical trials, reticence to actually take biologics, not understanding what these things really are and kind of how they work within the grand scheme of things. But, so just, getting people comfortable with some of these ideas and how their cultural nuances that go along with it, I think it's really important.
Yeah, no, I think it's really, and I've learned a lot from Sonia. Sonia was one of my attendees in fellowship. And so I think her point, and maybe you were saying the same thing, but your points are very good in that if you approach every single patient encounter the same way, you ask the same, not in a rote way, that's not what I'm saying, but if you approach every patient, you ask the same questions to every patient, and it becomes part of your routine assessment so that you know everything that you need to know about your patients. I think that that's the right way to do that.
Yeah, it's not making assumptions about people, which I think is really important. And I think, obviously we all make assumptions based on, our facts, but I do think we all come from a place of sort of having some things normalized. And so if you sort of stop coming, especially if that's the way, if I'm straight, then I'm going to maybe come from that sort of, and the society is sort of geared towards straight people, then that's probably going to be your default. So stop thinking, about the default and start talking from a place of just curiosity. And like you said, sort of, these are the questions we ask on a routine basis that help make the patient who they are and help us best formulate what's going to be best for them, including their, decisions that they prefer, like, I don't want to use a needle, or I don't want to eat meat, or if you're South Asian, my family needs to be part of this decision, these types of cultural nuances that come in. Or, hey, maybe talk to a dietitian who actually understands the type of cuisine that you eat on a regular basis.
Oh, that's so important, because when you think about disparities and you think about sort of differences in race and ethnicity, one of the things that I think has been brought up a couple of different times on different panels that I've been on is that, to your point about, if you're of an ethnicity that doesn't eat a Mediterranean diet, and somebody tries to present in very rigorous detail the DINE-CD study, and they try to tell you should eat a Mediterranean diet, well, that may mean nothing to you. That may mean, just like you eat macaroni and cheese or whatever. That's such a foreign concept to what your actual diet and what you've been eating, that you may turn away from that because you think it's just impossible, for the same reason that people stop clinical trials because they don't want to do needles, as you said before. So I think that all of those are really important points.
But also, do you know how many countries are on border the Mediterranean and how many different diets could be considered Mediterranean? So, I mean, a Mediterranean diet could mean so many different things to so many different cultures. So there's that.
Yep.
Good point, Robin. That's a good point. Well, and Kochi just had their conference, and there was a speaker there that was talking about also, because you started to bring this up, and I'm glad you brought this up, because it reminded me to circle back to it, is this idea of healthcare deserts and the lack of access that happens in certain places. And that also translates to food deserts as well. Typically, the same places that don't have access to healthcare also have not access to grocery stores. And so when you're talking to somebody about, and they had a speaker at Kochi that really went into depth talking about how it's very difficult and frankly more expensive when the only option you have for your groceries is a convenience store. And so how do you, as a practitioner, work with a patient who that is their access to food when, and because that's just, you're not going to be able to get the same quality, the same types of products. And also, frankly, they're going to pay more money because it's convenience. So, even looking kind of, again, taking that lens and broadening it out to what are we looking at? Is it healthcare deserts? Is it food deserts? And then how does that impact especially GI patients?
Well, it's all tied together. And I think that's what makes both researching this area hard, but it also makes solving some of these issues very difficult as well. Because if your access to care to an IBD center, for instance, is limited because you're in a healthcare desert, which is also a food desert, it's not a big stretch of an imagination to think you're set up to have a worse outcome than somebody that has access to fresh fruits and vegetables that they cook themselves, that they don't have emulsifiers, if we think those are increased with risk of flares, and that they can see their IBD doctor whenever they need to, and that they don't have to worry about 3 types of transportation to get to the gastroenterologist. How we fix that, I don't think we have tackled that very well. I mentioned before these issues with like broadband internet. And one of the things that I've been involved with in the last year or so with the AGA was called the AGA Future Leaders Program. And one of the projects that we were sort of tasked with was trying to solve some of these disparities issues. And so we came at this idea of access to care in rural areas and geographic disparities in rural versus urban areas. And we wondered if you actually could improve care by actually sending patients something like an iPad with a built-in hotspot, and that would be your access to an IBD center. Now, part of this comes down to actually finding patients that have Crohn's disease and ulcerative colitis, and that's something that's been difficult in the United States if you're seeing your primary care doctor because you don't have access to a gastroenterologist and you don't get a colonoscopy or a CT scan to know if you have ulcerative colitis or Crohn's disease, and you just get labeled as diarrhea or abdominal pain. You may still be in this disparities component, but at least we maybe increase access once we know you have IBD. Then I think maybe you have access to the other services that come with an IBD center that we alluded to earlier in our discussion, which are nutritionists and psychosocial support and all these things that come with an IBD center compared to a primary care doctor that doesn't specialize in gastroenterology, where we have access to pharma support and we have access to industry partners and we have access to free drug programs. And all of a sudden, all these things are opened up to you just by having that foot in the door to an IBD center. that you didn't have because you live 4 hours away. I think that's things that we still need to focus on. This has not been well researched to date in the United States, even compared to Canada, where there actually is some literature that the farther you live away from an IBD center, the worse your outcomes are. But I think it's all tied to this conversation that you really very nicely tied in with. It's not just how far you live from the doctor, it's all the other things that come with how far away you are in terms of geographic disparities.
Have you seen a significant change in the uptake of virtual care, just based on your comment about iPads, from the insurance industry, but also just in general from patients? Have you seen that in general, people are much more open to using this as a way to meet a specialist?
In general, yes. I would say that, until March 13th, 2020, we had no real capability to do telemedicine in our clinic. And then within 3 weeks, all of our cases were telemedicine. And so we just turned around. So I think the logical answer is yes, there is more of that. Now, there's all kind of barriers when it comes to insurance and with state lines and things like that I think we still haven't totally tackled. Because as I mentioned before, our catchment area is not just Chapel Hill or the Raleigh-Durham Chapel Hill area. We cover a multiple state area with our IBD clinic. And even now with telemedicine, we still can only do telemedicine for patients that live in North Carolina, unless we get a license in these other states. And so I think there's still some barriers like that it would be nice if some of those got resolved. But I'm not sure there's as big a push now because we're sort of moving out of the COVID era, if we want to think about it in a positive way.
But there's still a need for telemedicine because people are still not close to IBD centers. I was driving 6 hours to find an IBD specialist, and I'm driving 3.5 hours still to go to an IBD specialist. I mean, I live in a rural area. There is a major city that is actually the state capital that's only an hour away from me, but there's not an IBD specialist anywhere close to me. I have to go 3.5 hours to get to an IBD specialist. So there's still a need for that. Please, insurance companies, don't take away telemedicine.
Well, just again, going to access to care issues too. If you're living in Montana, the middle of nowhere, Montana, and you don't have the means to be able to fly places, you're screwed. Yeah. Anyway, sorry, rabbit hole.
Yeah. Yes, we are going to go down a rabbit hole because, if you're in Montana and you're a pediatric patient, you have to see somebody at Denver Children's or Seattle Children's, or where's your doctor? States away. So you're, Okay. Anyway, thank you so much, Dr. Barnes, for being on the show. We so sincerely appreciate it. But if you could just wrap this up in a nice little gift and had one piece of advice for our IBD patient community or the professional community or both, what would it be?
I want to wrap it up and say it for everyone. And that is that everyone listening to your podcast probably already knows this, but I'm going to reiterate because I think it's critically important. Patients with inflammatory bowel disease are resilient. And we as a field haven't done the greatest job in treating patients to date. If you look at the best medicines that we have, we still only have remission rates in the 50, 60%. That means 40 to 50% of patients don't go into remission with the best drugs that we have. From a patient side, what I hope you guys understand is that doesn't mean we're trying. Every single day, I'm trying to think about how we can treat patients with IBD better. And from the physician side, I think we have to have grace to know that patients with IBD are dealing with bad diseases and that we need to do a better job of treating them. And that should be what promotes us every morning to get up and do better. And if we all kind of approach it that way, I hope that we will be able to do better in the next couple of decades.
I love that. That's hopeful.
Yeah, I appreciate that. I think that's the perfect attitude to share with your colleagues because this is an audience that needs that type of passion for sure. Mm-hmm. So thank you, Dr. Barnes, so very much. It was so much fun to talk to you. Thank you so very much for sharing all of your insights and your wisdom and your passion with us. And thank you, everybody else, for joining us for the show. And cheers.
Cheers, everybody.
Cheers. Thank you so much. Hi, this is Ed Barnes. If you enjoyed this episode, please rate, review, subscribe, and definitely share it with your friends. Thanks again.